Welcome to the pIBD Digest, an educational podcast exploring pediatric inflammatory bowel disease, Crohn's and colitis. In each episode, we, your hosts, Dr. Tracy Coelho and Dr. Bakewell, are joined by leading experts to provide an insightful overview of these chronic conditions.
Our aim is to support both healthcare professionals and families living with pediatric inflammatory bowel disease by sharing knowledge, experiences, and the latest research. But please note, the views expressed in this podcast are those of the speakers and our guests and are for educational purposes only. They don't constitute medical advice.
Welcome back to the pIBD Digest, our little globe-trotting escapade. We have journeyed through sweltering climates, and now we are making a frosty swing north to a place where room temperature is just a myth.
Yeah, welcome back everybody. Tracy, I'd say we're probably a bit early in the year for our Christmas special, but why don't you give us a little bit of an episode teaser?
I'm sure our listeners can hear the Canadian national anthem in the background. Yeah, so today's destination is Canada, a wonderland of maple syrup, endless politeness, and surprisingly, or not surprisingly, one of the highest pediatric IBD rates worldwide. But more than that, Canada is a trailblazer for environmental IBD research.
That's right. So the topic of today's podcast is environmental risk factors in IBD. And this is a really important one because it's very much in the zeitgeist of the pediatric gastroenterology field and wider as well. And listeners, this is an especially important episode for me because it's very close to my heart. Around 2 years ago, it would have been very difficult to stop me from talking about the impact of ultra-processed diets on our health in just about every other sentence. And Tracy and the rest of the gastro team in Southampton will attest to that, I'm sure. Sadly, I've since stopped making my own bread at home, but it seems that the research and, to an extent, society in general, have forged ahead with keen interest into how the way in which we live our lives and the environment around us shapes our health and our risk of disease.
Listeners, I can confirm the gastro team in Southampton are probably still recovering from PTSD after Dr. Bakewell's ultra-processed food rants. And as for the tragic tale of abandoned bread making, well, maybe it's for the best. Otherwise, this podcast might have turned into an ultra-processed version of the Great British Bake Off, with a side of IBD.
Yeah, I'm sure there's a pun on Bakewell in somewhere there. All right. Should we tell our listeners about today's Canadian guest?
Sure, our guest today isn't just any expert. Well, I say that about every guest, don't I? But honestly, today's guest is a world-renowned mogul in IBD research. With scrolls of published enlightenment that seem endless, his work in IBD epidemiology is truly celestial. So no more waiting, here we go, paging Dr. Eric Benchimol. Welcome, Dr. Eric Benchimol, to the pIBD Digest. It's a great honor to have you on this podcast.
It's an honor to be here, Tracy and Chris. I've enjoyed the podcast episodes I've heard so far.
Thanks, Eric. I was secretly hoping Tracy would kick us off with something like Purple Rain, but clearly his royalty-free library has let him down somewhat.
No Purple Rain for intro music, but certainly a poem on Purple Rain if listeners stay tuned till the end.
I think my reputation precedes me, obviously. You know me already. You know me well.
So for our listeners, Dr. Benchimol is a leading pediatric gastroenterologist at Sick Kids in Toronto. He's also a professor at the University of Toronto, a senior scientist at the Sick Kids Research Institute, chair of the Canadian GI Epidemiology Consortium, and co-chair of more committees than I could list without running out of breath. So I'll spare our listeners the endless list of publications for now. And despite all of this, I may have barely scratched the surface of your professional profile. But do you think this is a fair summary, or should I have asked ChatGPT to work a bit harder?
That's great. I'm surprised ChatGPT was so accurate. I guess you used GPT-5, right? It's supposed to be better?
Yeah, quite possibly.
Yeah, I think the one other thing is that recently I've taken on the chair-elect role of the Canadian Children IBD Network, or KidsCan, which is a really nice network of researchers in Canada doing great work in pediatric IBD. So I want to plug them as well.
Sure, thank you. So with that whirlwind summary of who you are, sort of a highlight reel that I've just done, now I would like to rewind a bit. So what's been your professional journey to get here?
Well, it's a long story. I knew that I wanted to be a gastroenterologist from medical school when I required an upper endoscopy. What ended up being H. pylori and an ulcer. And they didn't sedate me well enough. And I watched it on the screen while gagging and retching and had a great time thinking this is something that I would like to try to do. And so that was during medical school. But, this typical training of residency in Ottawa, Canada, and then fellowship at Sick Kids. I fell in love with research at Sick Kids when I was a trainee. I never thought I'd be a clinician scientist, where about 75% of my job is research related. It really was a surprise to me that I liked it that much and was that stimulated and challenged by it. I really enjoyed the challenge and the ability, the feeling that I could make a difference in a bigger scale than only treating my patients, although I still love treating patients. And so that exposure to that type of role at Sick Kids really made a huge difference. I worked in Ottawa for 10 years again after my training, and then came back to Sick Kids in Toronto in 2020 at the height of the pandemic, and have been there for the past 5 years.
Eric, I listened with great interest to your interview that you did for Bowel Sounds, which was amazingly 5 years ago now somehow.
Yeah, it was a while ago.
Sadly, time flies. And for our listeners, that's the North American equivalent, so the Naspagan podcast. And there's infinite things we could talk about. I was really fascinated by what you spoke about in terms of efficiency and time management. It sounds like you've got a lot of insights to share into how you manage what is clearly a very amazingly busy professional schedule. And we could almost certainly fill this whole podcast on that topic alone. But sadly, we don't have time to cover everything. So if it's okay with you, what we wanted to focus on today was something I think is close to your heart from research and also professionally, but how the environment around us influences the risk of developing IBD within our childhood years.
Chris, I think it would be great if Eric could share his favorite tips on personal productivity and efficiency. In fact, I read his very famous paper, How to Live Life Like an Academic Athlete. And I'm sure your tips would go a long way in helping us run this podcast even more efficiently. Chris, what do you think?
I haven't read it, I will say, but I'm sure it's amazing. I'm sure it would.
So I feel like this may not be the best time in my life to talk about it, as I've struggled for the past 2 months to try to find time to write a grant that I definitely need to write by the end of next week. So I'm not the best example of productivity and organization right now, but that tells you about, I guess that message, right, is maybe say no to more things is a message that I should have taken to heart a few years ago, probably.
It's important to be human as well.
Absolutely. And I still love what I do. So that's what's important in the end. Right?
That's great. Thank you. Now, as I understand, you always have music in the background, high energy music to energize, a motivational playlist for focus. So do you think we should have played a soundtrack while we ask you questions? Or do you think Chris's questions will be sweet music to your ears?
I think you gentlemen will do a great job asking me questions and keep me focused. When I have a camera on me, it's very hard not to stay focused. And besides, when I focus, I have my own playlist, right? So if it's a different person's playlist, I don't think it'll work for me. I need my own playlist that I focus to.
It can be incredibly hard to stay focused when Tracy's asking questions. I will say that. So just lock in. And so clinical stuff, right? So you've, of course, published extensively on the IBD incidence in Canada. So starting off, how common is pediatric IBD in Canada? And I guess as importantly, how does that compare with the rest of the world, Western world and developing nations?
Yeah, I mean, so Canada has one of the highest rates in the world of IBD, not just pediatric IBD, but IBD overall. And we can talk about why that might be, but the honest truth is that nobody's exactly sure. The projection is that by 2035, about 1.2% of our population will have IBD, either Crohn's or colitis. And the pediatric rates, while lower than the adult rates in terms of incidence, are, again, amongst the highest in the world. when we did a systematic review a couple of years ago, the only country, I believe, that was that reported higher incidence was Norway. Otherwise, we were the highest incidence in the range of 10 to 12 per 100,000 per patient year. So quite a high rate, and seeing that rate rise continuously in Canada as well. It still hasn't leveled out.
And how does it compare to somewhere like the States? Like sort of, very similar demographic, I suppose, but different geography.
Yeah, so I would anticipate it's similar to the States, but we don't have great population-based data from the States. Jim Lewis and Michael Kappelman just published in the past year or two papers, one in pediatrics, one in adults. The adult one, I think, was published in Gastro, looking at combining HMO data to report on incidence and prevalence. The difficulty is that there's big chunks of population missing there, and there's methodologic issues that we're not 100% sure that it's completely population-based, but it was a good estimate, and I think the rates were very, very similar to Canada, although their age cutoff was less than 20, whereas in Canada, pediatrics is less than 18, so slight differences there. I think that they're similar, especially in the northern United States. There seems to be in Europe a north-south gradient, where it's higher in northern countries and lower in southern countries, and whether that's sunlight exposure, diet, ethnicity, we're not sure. But it seems like as well in North America, the northern states probably have similar rates to Canada, the Canadian provinces as well.
Yeah, and of course, we're going to touch on some of those risk factors and why that might be. But just overall, do you get a sense of why Canadians seem to have a higher risk? I mean, it seems, just speaking objectively as someone external to Canada and having only been there once for a very beautiful tour of sort of the Rockies, it seems like a very healthy environment to live, very rural, very sort of, a lot of outdoors. And then just following up from that as well, does that high rate give us an understanding of some of the factors that influence IBD? Because it must be something about Canadians or Canada itself.
Yeah, I mean, I think it does help us try to start to look at environmental factors and reasons why. It is unclear as to why Canada has such a high rate, and we're not homogeneous either. So places like Nova Scotia, which is the province on the easternmost shore of Canada, has very high rates, much higher than the central provinces, and British Columbia has lower rates. Again, we're not entirely sure why. The British Columbia phenomenon may be related to immigration from East Asia. And we know that people from East Asia have low rates, both when they're at home, and that group primarily are from China and Hong Kong, but also when they arrive to Canada. Whereas in Ontario, where I live, which is Canada's most populous province, our number one immigrant group is people from South Asia. And what we found is that while people from South Asia have lower rates when they're in South Asia, their rates when they're immigrants to Canada are still lower than Canadians. However, the younger they immigrate, the more they get IBD, as well as the children of South Asian immigrants who are born in Canada have the same rates, high rates of developing IBD as the children of non-immigrant Canadians. So clearly there's, a population effect of a genetic risk factor being triggered when you arrive to a place with a high background incidence and that environmental risk factors of developing IBD. So I think possibly our ethnic diversity plays a role in increasing the rates of IBD in Canada or resulting in our increased rates. But likelihood is there's other things. In the end, Western countries right now, or at least Westernized countries, are more likely to have IBD. And obviously Canada is a Westernized country. We are predominantly urban. For example, in Ontario, about 85 to 90% of our population is urban, and even rural people, the vast majority live along the border with the United States. So they're not far from a city like Toronto or Ottawa or Hamilton. So we are predominantly an urban country. And then again, whether vitamin D is playing a role and sunlight exposure in the northern latitude, we're not entirely sure. Whether diet's playing a role, we're not entirely sure, westernized diet. But, I think we probably, unfortunately, have the perfect mix of factors and the perfect genetic background in terms of our immigration population to have this high rate.
And you're still seeing lots of very early onset because, of course, you've talked before about how it's not just it's pediatric IBD, but it's also those kind of less than 6, less than 5-year-olds, which were very, very rare historically, but now seem to be becoming more common.
Yeah, for sure. Absolutely. And I have to say, I trained way before you, Chris. But when I trained, it was very rare to see a child under 5 with IBD, really rare. And now we see it all the time. And we've developed specialized clinics in order to treat those children. So that's actually the one group, those very early onset IBD group is the one group that is statistically rising in terms of incidence in Canada. And that the group under 5, they were rising by about 8% per year of a study that we did a few years ago. Whereas each of the older age groups, they were rising, but it was not statistically significant. So that's why overall our population of pediatric IBD is rising. But it's really that very early onset IBD that is driving things. And we can discuss why that might be. If you want, we can do that now. I'm sure you'll ask, but it's, I think it's probably a combination of factors, right? I think it's a combination of, for sure, better access to care. We have more pediatric gastroenterologists. We are more likely to perform endoscopy on a child with symptoms of IBD. There's more awareness of IBD as a possibility. And then there's the group of monogenic IBD where maybe they weren't called that before, but we found genes affecting their immune system, and some of them may have passed away early in life, and we never knew that they had this form of monogenic IBD. So I think awareness is definitely an issue, but it's hard to believe that we missed all of these children. Predominantly very early onset IBD is colitis, right? So it's hard to believe that we missed kids who are having bloody diarrhea at 5 years old or 4 years old, well past the age of food protein intolerance, for example. I think there is something real and something environmental that's increasing those rates.
And I suppose what from what you're saying, what you're not seeing is a reduction in the older children being diagnosed. You're not shifting it forward. I mean, there are more under 5 proportionally that are increasing, but still you're not seeing a reduction in the older children, i.e. it's not just picking them up earlier. There must be some other exposure factor or something else.
Yeah, exactly. Although we are starting to see in some provinces a reduction in the adult onset IBD incidence, right? So not prevalence, but incidence. So perhaps everything is shifting earlier. But again, I think it's hard to believe that we were missing all of these kids 5 years old before.
Eric, what you have just said aligns quite nicely with our previous episode on monogenic IBD. Now, if I shift gears a bit, you have a wide list of publications. In fact, I remember citing some of your work for my papers on thiopurines.
That is digressing a bit.
Yeah, I have to say I haven't used a thiopurine in a very long time. Tracy, so I don't know how old that paper is, but
yeah, I know you guys in North America are not big fans of thiopurines. But what I wanted to ask you was, how did you gravitate towards epidemiology or environmental factors in IBD as your core research interest?
Yeah, so that I have to attribute to Anne Griffiths, my mentor in Toronto, who, when I was a fellow, we all do a research project for our second and third year of fellowship. And, I was interested in clinical research, specifically with patients. And she suggested I go to speak with a general pediatrician named Astrid Gutman at Sick Kids, who was really the only pediatrician in the province using provincial health administrative data. And Anne's thought was, well, Charles Bernstein did all this work in Manitoba, and that's really the only place that's done anything, and he's primarily adult focused. Why don't we try to use the Ontario health administrative data to look at pediatric onset IBD in the province? And obviously a very large province, 14 million people, we would be able to answer some interesting questions about rates and outcomes and things like that. And, that was the focus of my PhD thesis, was to start to look at the rate of IBD in Canada, outcomes, and that led to the ability to look at environmental risk factors, because our data housed at a place called ICES really is linked to all sorts of population-based data sets, environmental data sets, socioeconomic data sets. We're able to look at many, many different questions. And that's also led to my other research focus, which is to improve the methodology that we use health data, large routinely collected health data sets, and move that area forward.
And that's really important, isn't it? Because people might not realize how important that is, but you've talked previously about validation of this data, because you're inferring quite a lot, and I'm sure it's very difficult to control for a lot of these variables. So at the base, you have to make sure that this data is correct. diagnoses are correct, that you're interpreting it in a meaningful way, because the effect might be small of some of these things you're seeing. And it's possible that you over or under interpret one through another if you haven't gone through that validation process.
Yeah, validation is important. The methods that you link data sets are important when it's not just a single number that you have available. You might have to link with name and date of birth and so on. And then now, in the age of AI, our methods of analyzing the data sets have changed tremendously. And so now we need to make sure that methodology is rigorous, and things like power and error are very important to consider as well.
I'm really impressed with the amount of homework my co-host has done about your research work.
I am as well.
So now, earlier episodes of this podcast have explored how Western lifestyles, rapid urbanization might influence IBD, and you have given us an overview already. But from your perspective, which concrete elements, dietary shifts, environmental exposures, microbial changes, which from your perspective are the most significant in driving IBD? It's a very difficult question, so I'm sorry.
Tracy, I need to pick one. How many how many choices do I get here? And that's honestly, I'm joking, but it's the truth. I don't think it's any one or two or even three factors, right? I mean, I think everybody is studying their own niche of their own sort of silo, whether it's diet, whether it's air pollution, whether it's, I think it's going to be, I think it has been found to be really all the combination of different factors. And I think it's a complex interaction. I do believe that in the end, at least part of this comes down to how this interaction of environmental factors affects the gut microbiome, and how then the gut microbiome, and I say that as not just bacteria, but also the virome and the fungome, and how all of these factors trigger the immune system to react or overreact. But in terms of which factors I consider to be important, obviously the classic environmental factor that we all learned about in medical school with Crohn's disease is smoking cigarettes. And that remains important, not so much in our pediatric population, although secondhand smoke definitely has been associated with the development of Crohn's disease. It's not as strong an association as firsthand smoke. I think that early life antibiotics is sort of another one of those classic risk factors, which now more clearly we can understand is mediated through the gut microbiome, and that permanence of the change that early life antibiotics play in the gut microbiome in developing Crohn's disease later in life. I should say that when you look at risk factors, environmental risk factors in an epidemiologic study, obviously we quote things like odds ratios, hazard ratios, incident rate ratios. Many environmental risk factors increase your risk, but that increase in risk might be sort of, for example, an odds ratio of 1.1 or 1.2. While that might be statistically significant, you have to remember that it's significant only because we're dealing with tens of thousands or hundreds of thousands of people, right? So any small change, you're going to find a statistical difference. When we talk about really clinically or epidemiologically or public health significance, we're talking about odds ratios of at least 1.5 to 2. And the greater than that means like a really strong epidemiologic phenomenon. So when you look at early life antibiotics, a study again from Charles Bernstein from Manitoba found that antibiotics within the first 2 years of life increased your risk of developing Crohn's disease, and that odds ratio was 4.5. So 4.5 is a very, very significant odds ratio. Whereas when we talk about things like prenatal exposure to smoking or secondhand smoke, the odds ratios are in the range of 1.1. So not as significant. So I do believe that antibiotics play a big role in this.
And I guess you could kind of lump that in. It's difficult because I don't know where the data is in terms of this next point. But if you're talking about when your microbiome builds itself and you develop this architecture, it's around between 1 and 3 years. By the age of 3, you've loosely got the architecture you're going to have. Then how much do you think things like cesarean versus vaginal, if you're North American, vaginal birth, breastfeeding, things like that, because those will all contribute to how well you develop a healthy architecture?
So it's very controversial, all right? So obviously some studies have shown that vaginal birth protects you, C-section increases your risk. There was a meta-analysis that was published recently which showed no association between birth delivery method and the development of IBD. So if you believe, these larger systematic reviews and meta-analysis, those may not be associated. But certainly breastfeeding, there was in a recent systematic review and meta-analysis published, I think in 2017, quite a strong association, protection. And the numbers that I've got are breastfeeding for at least 12 months. The odds ratio of developing Crohn's was 0.20. So in colloquial terms, an 80% reduction in your risk for Crohn's, and ulcerative colitis 0.21. But you do have to look at how those studies included in the review were done. And, did they document very clearly how much breastfeeding was, how exclusive it was, how prolonged, like how many months of exclusive breastfeeding, and methods play a big role. And when we start to talk about diet, we're going to talk about how it's such a hard thing to study, right? I mean, documenting breastfeeding is hard enough in large studies. Documenting diet is even harder. So I think there is something there.
Especially large scale retrospective stuff, right? Because how can you possibly know what people like? You've loosely.
Absolutely. Yeah, absolutely. Yeah. And even prospective studies. We've got excellent prospective studies in Canada. Things like what's called the child cohort, looking at environmental risk factors, mostly for atopy and allergies, although they've moved now to more immune-mediated diseases. And then you've got large cohorts collected prospectively of birth data. And even then, it's very hard to be sure that your data is completely accurate. So we're working on it, but it's tough to do. But in the end, I do think that early life is key. And some of the studies that we've done have shown that as well. So I talked about the immigration study, where the earlier you immigrate to Canada, the higher your risk. And the children born in Canada have, at least from people from South Asia, have similar very high rates, whereas people who immigrated from other places like East Asia, the children remain not at risk, very low rates. But we see this with urban-rural, the urban-rural story, where we know many studies and many meta-analyses have shown that if you live in an urban area, you're more likely to get IBD, both Crohn's and ulcerative colitis, compared to where you live in a rural area. And there was a German pediatric study which showed exposure to farm animals was protective. But what we've seen in Canada is, yes, that is true, but early life exposure to the urban environment is what put you at risk, or conversely, early life living in a rural environment protects you. And that effect goes away with adult onset IBD. So it's not as significant when you develop IBD as an adult. Similarly, green space is an interesting story. We found that the greener the environment you live within the first few years of life, the less likely you are to develop IBD, both Crohn's and ulcerative colitis. And there's both a dose-dependent relationship where more green is better than less green, and also a time relationship where the longer you live around green space, the more protected you are. So I do think that there is something about early life exposure. And I mean, if I was a policymaker, public health person, or advocate for changing urban planning and policy, that would be the group that I focus on, right? Is looking at what are kids being exposed to rather than what are adults being exposed to. But I'm also a pediatrician, so I'm biased.
That was going to be my final question, but I'll say it now then, because when you talk, you're obviously very passionate, and it takes a lot of energy and enthusiasm to undertake these research studies. And do you find yourself moving more towards public health? Because these interventions are public health interventions. It's very difficult in a clinic to say, well, you've got one child with IBD, move to a farm for the next one. These are large scale interventions that you're, I guess, recommending off the back.
So Chris, I like to dabble in a lot of things, right? So moving towards public health implies there's purposeful thought to where I'm headed towards. In fact, I kind of enjoy letting the data and letting the research take me where it's going to take me. I do some public health research. I do some environmental epi research. I do health services research, and I even still do clinical research. So I do think that advocating in the public health realm will probably be where we have to focus to prevent the disease in the long term. I think it's difficult to do right now, mostly because in order to really have an effective public health intervention, you have to have a number of factors in place. And I don't know if you've heard Wilson and Youngner's criteria guidelines for screening for a disease is really useful to think of from a public health perspective. And I can sort of list some of them. Obviously, IBD is an important health problem. There is an accepted treatment. There are facilities available for diagnosis and treatment. And there is a recognizable latent or early symptomatic phase in which you could potentially intervene to prevent the disease. Do we have a suitable test for screening patients, right? People, right, who haven't developed the disease yet? Not yet, but there's certainly people working on it. The GEM study run out of Mount Sinai Hospital in Toronto has developed an integrative risk score using AI to try to predict of first-degree relatives of people living with Crohn's who's going to get the disease later on. And they have developed a score that is quite highly predictive. It still needs to be validated, and that is specifically in first-degree relatives, right? So we don't know if that will apply to the general population. But maybe within a few years we'll have, or within 5 years, we'll have a screening test. Is there an agreed upon policy on who should be treated? Yes. The cost of case finding should be economically balanced. We haven't even started looking at that yet. And case finding should be a continuous process, which we can imagine one day where it might be. So there's still some factors in there in terms of screening that we're not quite there yet. And then the question is, can we intervene to prevent the disease once we've screened everybody, right? And unlike the type 1 diabetes story, there is a biologic that will prevent type or delay the onset of type 1 diabetes for a number of months or years. And so there's lots of research now going on screening of type 1 diabetes to try to prevent the disease in children. We don't have that yet in IBD. Maybe we'll develop, maybe anti-TNFs will prevent the disease in people who are at high risk. We don't know. But we need something to be able to prevent the disease before we start going to public health and say, let's screen everybody.
I was just a quick question. Sorry. It strikes me that we're 5 years now since the start of COVID, and we've talked a bit there about, I guess, hygiene, living on a farm, living in rural areas. You potentially, what you're talking about is there's lots of factors, healthy lifestyles, exposure to fresh air, all those kind of things, but also hygiene. And the hygiene hypothesis, there's been studies looking at the number of toilets in the household, the number of people in your household, and risks of IBD, where you get your drinking water from. Have we learned anything yet from COVID about the hygiene hypothesis, or do you think that will come, given that we had a cohort of people that weren't mixing?
Yeah, we haven't learned anything yet, as far as I've seen in the literature. And I think it's difficult, right? Because yes, you could study that population, but the problem of access to care was also a problem because of the pandemic and the lockdowns, right? So we know that there's a whole group of people who were delayed in accessing care and delayed in seeking treatment in all sorts of diseases, not just IBD. And the people who presented were sicker. And that's sort of an anecdotal experience that I felt during COVID, was that it was less likely that they presented to an outpatient clinic. They were more likely admitted through the emergency department and so on. And so I think, again, there's that whole confounding of access to care during COVID. And as far as I'm aware, there was not really any, unfortunately, prospective population cohort study to, follow these people to see what happened. And we were too wrapped up in dealing with COVID. So I'm not sure that we're going to learn, unfortunately, learn much from COVID, which that has all too often been the theme of COVID. But, I think it's the right question to ask anyway. And I think that we need to start to look at it. The hygiene hypothesis is interesting. Again, I think it's never as simple as one single explanation. But I do think that there is something to exposure to bugs, playing outdoors, socializing, being in a household with more children, sharing towels, for example. I think there is something to hygiene and multiple immune-mediated inflammatory diseases, not just IBD. And I think that is worth looking further into. That being said, it's not really an intervention that we can act on. We can't put more people in people's homes. But
have you thought about sharing towels in clinics?
Yeah, no, I don't think that would go over very well with our infection control people. But, encouraging children to play outdoors, encouraging children to play in sandboxes, even though parents might get grossed out about it, allowing children to get dirty. I think there is something to that in terms of producing a more naturally functioning immune system.
Eric, if you remember the traditional Venn diagram on the etiology or causation of IBD, from all that we have just discussed, it appears that this traditional Venn diagram that we all know of will only get overcomplicated or possibly cease to exist.
Yeah, I mean, it's still put up as the first slide of every talk in every IBD presentation that we see today, right? There's a fourth circle now with the microbiome. It used to be genetics, environment, and the immune system. Now the microbiome is in there somehow. Is it all that useful? I don't think so. I think, more a DAG, like a directed acyclic graph of looking at confounders and effect modifiers and strengths of association is much more the way to think about it. It's very complex.
Yeah. Now, you've already mentioned about climate-related factors, living in colder climates. You also briefly mentioned about vitamin D. I know there were several publications years ago. Has there been any interest in that lately?
Oh, yeah, absolutely. So there's been multiple publications that have shown that low levels of vitamin D is associated with, not causes, but is associated with the development of IBD and is also associated with flare-ups of IBD. And in fact, recently out of Saint-Justine Hospital in Montreal, there was a randomized controlled trial treating patients with IBD with vitamin D supplementation, and it did not show a significant benefit in their primary outcome of reduction of flares, unfortunately. But again, association is not causation. We don't know whether low vitamin D is associated with IBD because it causes IBD. It changes the microbiome. We know that. It modifies the effect of certain genes like NOD2 in IBD. There's, vitamin D ligand is associated with the immune system in NOD2, or whether it's a marker for, other environmental risk factors, living in northern countries, diet potentially, and other things. We just don't know yet. So I think there's something to be said for looking into vitamin D as a preventative tool, but we're not quite there at saying we recommend vitamin D to prevent IBD. I certainly I live in Canada. Everybody should be having vitamin D. Like, there's no doubt the recommendation in Canada is everybody should be on 1,000 units of vitamin D per day. We just don't get enough sunshine, especially in the wintertime. But I do recommend vitamin D for all of my patients, and we do monitor vitamin D levels once or twice a year to ensure that they're, normal, and we increase the dose of vitamin D as necessary.
I mean, it kind of makes your head hurt a little bit when there's so many questions I want to ask you, because there's so many things you can think of that could impact your risk of getting IBD. And also not just that, but the risk of flares and your course of IBD and things like that. You said 75% research, is it 25% clinical? So you still run clinics, see patients face to face. In the clinic then, if you've got a family who are asking you, what should we do to avoid the risk of other children getting IBD, or what should we do to, what lifestyle interventions can we make? What are you telling them? Because they're going to get a lot of information from social media now. It's really a tricky world to navigate now that everyone has all this information and can interpret it in any way that they choose to. Epidemiologists will say, be cautious. This is not causation, it's correlation. But that doesn't stop the individual family from seeing it as significant. Is there anything that you do recommend or anything you say to them?
Yeah. So firstly, I caution them that we don't really know, right? We don't know if any of this will prevent it. And there's not much that we can do really to prove any of this. What I typically tell them is a good, healthy lifestyle, playing outdoors, playing in parks, exercising, being around other people is best. Trying to get off the video game screens, increasing physical activity. There's many reasons to suggest that outside of preventing IBD. And then the other thing, for better or worse, what I do recommend right now is dietary interventions. And really, the primary thing that I recommend is avoiding of ultra-processed foods, which I do think that there's something there. We haven't proven it yet, but there seems to be something there with both ultra-processed foods and emulsifiers, which is a part of ultra-processed foods, that changes your microbiome and seems to change your microbiome in an unhealthy way in general, in terms of obesity, mental health, and immune-mediated inflammatory diseases, but it's still unproven. So, a good healthy diet, naturally grown foods, home cooked meals, no ultra processed foods. And then I do often tell them that there might be an association with the Mediterranean diet as a protective factor, although that is unclear as to whether or not that's true. And we don't know what component of the Mediterranean diet. I certainly don't recommend that all children drink red wine, but everything else, lower processed foods, more fish oils and omega-3 fatty acids and less red meat may actually prevent it.
Well, you very much validated me, because you haven't heard the intro because we recorded it before you started. But I about 2 years ago, I read a very famous book in the UK called Ultra Processed People, and I wouldn't stop talking about it for about a year.
Yeah. I think we're early in our understanding, but it's certainly, at least for us at the Canadian Institutes of Health Research, our national research funding organization, government funding organization, the NIH equivalent. Ultra-processed foods has become a very hot topic and an area of interest for many different diseases, not just IBD. So I think we're going to learn more over the next 5 years as to whether ultra-processed foods really have a strong adverse health effect and what exactly is going on, particularly how it mediates the microbiome.
So I guess, we have to at some point draw this to a conclusion, and it feels like the next question is, logically, what is next? Do you see a world where we keep looking for these individual factors, big data models, AI, trying to seek out what the most important factors are? Or is it more about looking at what we already know, i.e. the microbiome, childhood exposures, breastfeeding, whatever we've talked about already, and really honing down on individual things that we already partly understand?
Yeah, I think it's going to be probably a combination of both, obviously, but I think that this idea of precision prevention, so we know about precision medicine, where we take the individual characteristics of a person and tailor the therapy to exactly those characteristics that we think will work. Precision prevention may be very similar, where we develop risk scores based on environmental factors, ethnicity, where the person lives, what environment and what diet they have, but also their biologic markers, right? So you may have serum tests that then can add to that score, develop an integrative risk score similar to what GEM has done, the GEM study has done, and start to screen and potentially prevent. I think AI will revolutionize this. I think the days of, even though this is what I've done for the last 15 years, the days of a hypothesis-driven identification of individual risk factors are probably going away. And AI is also going to allow us to better understand the interactions between various risk factors and how one might modify 2 or 3 in order to then change the microbiome and change the risk. So I think AI is really going to revolutionize everything, assuming it doesn't destroy us all first.
So, Eric, I think we are nearing the end of our recording. This is a very non-medical question. I know you're a very big Prince fan, but what I can't help noticing in the background, there is Taylor Swift.
There is Taylor Swift and Fiona Apple. So Prince will always be my number one. Like I am a very big Prince fan. I've seen him live 7 times, and by far the best live performer I've ever seen in my life. But yes, my musical tastes are diverse. I like hip hop. I love Taylor Swift. I've become a huge Taylor Swift fan in terms of her songwriting ability. I'm not a pop music fan, which is interesting, but the songwriting is phenomenal and her productivity is amazing. But I'll listen to alternative. I'll listen to hip hop. I'm not a huge classical music fan. I'm not a huge heavy metal fan, to the despair of my son, who loves heavy metal music.
And not Taylor Swift.
And definitely not Taylor Swift. Although he sent me on Instagram today, he sent me an AI recording of Taylor Swift doing a heavy metal guitar solo.
He's trying.
He's trying, definitely trying. But yeah, I'm a big music fan overall, for sure.
So, Eric, I think we will need a sequel episode for all the other questions popping in our heads. But unfortunately, that's all the time we have for today. It's been an excellent discussion. So much to learn and share with the GI community. Thank you so much for your time, especially for juggling the time zones to make this happen. Thank you so much.
No, thank you very much, Tracy and Chris. I've really enjoyed the conversation. It's been great.
Really good. Thank you so much, Eric. That was really great.
All right. Okay. Take care.
Take care. Bye-bye. Dear listeners, as mentioned earlier in the podcast, our guest today is a great admirer of Prince. As a tribute, my poem today carries the title After Tears of Purple Rain. While it doesn't share the same meaning as in the song Purple Rain, it speaks of the emotional journey patients and families go through when faced with the first wave of a chronic diagnosis. After Tears of Purple Rain. When diagnosed, sometimes it seems life at random is pushed so screechingly in the crashing lane, where exit so seemingly obscure bears the darkness of unseen emotional pain. As the happy prints of normal living seem washed away in sheer disdain by the falling tears of the so-called purple rain. A disclaimer though, the real meaning of the celebrated Prince's song, my verses may not quite explain. Though stifling and disheartening, it all feels as the journey begins, when life in all its glorious forms may seem nothing but all in vain. But trust me, as someone seeing this over and over again, emotions as these do not always sustain, as treatments seek to usher in light, with ill health slowly dripping down the drain. Just like the kiss of rainbow, smiling in positive radiance, breaking through the aches and pain of this so-called purple rain. Thank you. Dear friends, thank you for your patient listening. I hope you enjoyed the episode. Have a great day and see you soon for the next episode. Take care and bye-bye.